Now, students, I have to continue the hypolipidemic drugs. Today, I am starting with the classification of hypolipidemic drugs, and the first line, therapy is HMG-CoA reductase. That it is the 3-hydroxy 3-methyl glutaraldehyde coenzyme A reductase. And in this, we have to have so many drugs, like we have a lovastatin, simvastatin, pravastatin, atorvastatin, rosuvastatin, pitavastatin. Then we have second class bile acid sequestrants resinous, cholestyramine, cholestyramine. Then we have inhibitors of the intestinal absorption of the cholesterol, that is stenol esters, ezetimibe, EZETIMIB, and we have CETP inhibitors. The full name of it is cholesterol ester transfer proteins. It consists of the torcetrapib and anacetrapib. And we have to start with the second line. We have other second line, like we have lipoprotein lipase activators, or the short name is PPAR alpha activators, fibrates. We have clofibrates, gemfibrozil, bezafibrate, and fenofibrate. Then we have lipolysis and triglyceride synthesis inhibitors, like we have nicotinic acid, that we call it the niacin, and miscellaneous agents we have gugulipid and fish oil derivatives. And now HMG-CoA reductase inhibitors are also called as statins. The statins are the most effective and best tolerated agents for treating dyslipidemia. These drugs are competitive inhibitors of the HMG-CoA reductase, which catalyzes an early rate limiting step in cholesterol biosynthesis. Now, history. Statins were isolated from the mold Penicillium citrinum and identified as inhibitors of the cholesterol biosynthesis in 1976 by Endo and colleagues. The first statin studied in humans was Compactin, renamed Mevastatin, which demonstrated the therapeutic potential of this drug. And now Albert and colleagues at Merck developed the first statin approved for use in humans. Lovastatin, formerly known as the mevinolin, which was isolated from Aspergillus terras. Pravastatin and simvastatin are chemically modified derivatives of the lovastatin. We have fluvastatin, we have rosuvastatin, and pitavastatin are structurally distinct synthetic. So we have natural, we have synthetic also. Now this is the HMG-CoA reductase inhibitors. The pathway acetyl-CoA enzyme goes to HMG-CoA. Then this reductase is inhibitor where there is a red spot, and there it is not formed mevalonate. Mevalonate is not formed, so the other cascades of reactions are being stopped. So it does not get this this chance to it inhibits at this point. So that's why we call it HMG-CoA reductase inhibitors. The inhibition of the cholesterol biosynthetic pathway is very important over here. So this is the cycle which you have to go through. Not necessarily, but in biochemistry you would have already covered this. Now LDL is also reduced by enhancing the removal of the precursors of the LDL, that is VLDL and IDL. So naturally it is being reduced. Reducing hepatic VLDL production also leads to reduction. So VLDL it is also reduced. So naturally the production and leads to the reduction in the level of the LDL. And this also reduces the level of the TG. So LDL, VLDL, IDL, and TG are being reduced. So these components are not being formed by inhibiting this enzyme. So the therapeutic dose of reduced CH cholesterol synthesis by 20 to 50%. It ranges from. This is the efficacy of the drug. This results in compensatory increase in LDL. So once it is reduced, LDL is going up. These receptors expression on liver. So when the liver these receptors are being overexpressed, increased receptor-mediated uptake and catabolism of IDL and LDL. Naturally, the IDL and LDL will be, it is uptake and catabolism will ensue. It will be given a brisk reaction. Over long-term feedback, induction of HMG CoA reductors and tends to increase CH synthesis. So in the long run, we have this synthesis is being, increased, but steady state is finally attained. But steady state is attained. How much it is, absorbed and how much is eliminated, it is being absorbed. It is being maintained. Now actions, effects on the lipid levels, effect of TG, significant reduction in TG levels, 35 to 45% you have to remember. If the TG is more than 250, then only this ensues. If TD is less than, maximum reduction is 25%. So the more the level of the TG at the baseline, the more is the effect. If it is less, the less is effect. So LD is also reduced. LD is also reduced here. So these are the different effects of the LDL depending upon the statin is dose it is dose, the degree of reduction in the level of the LDL ranges from. So we have a fluvastatin, it is given in the 20 to 80 milligrams and the percentage is 20 and LDLC maximum dose is 35. So maximum dose also. Pravastatin we have 10 to 40 milligrams, it is 20% and 35 is the maximum dose. Lovastatin 10 to 80 milligrams and it is 20% reduction and 40 is the maximum dose which has been tolerated. Cirvastatin is 0.2 to 0.8, so it is more potent and 20% and 40 is the maximum dose. Simvastatin 10 to 80 milligram is 26, then it is 50 maximum dose. Atorvastatin, you see this is the drug. 10 to 80, the dose range is from 10 to 80 and 31% is the reduction in the LDL. And then we have a 50 milligram, 55 milligram. Then rosuvastatin is 5 to 40 milligrams, so the dose is very less, but it is up to 40, so it is more potent than the atorvastatin, and 36 is the percentage reduction. So nowadays rosuvastatin is the drug is given and 55 is the maximum dose which has been tolerated by the patient. And the effect of HDL, increase irrespective of the dose, so it increases, so it is a very good cholesterol, it should increase, and statin is used if the HDL is less than 35 milligram. The effect may be variable, so it may be variable. Simvastatin produces greater increase in HDL and ApoA1 level than atorvastatin and rosuvastatin. So if you compare the simvastatin and the atorvastatin, rosuvastatin, the HDL and ApoE level is more than, it is good, it is reduced in a good way than atorvastatin and rosuvastatin. Level of LP is not affected by the statins. So this level is being maintained. Now the direct cardioprotective effect. Statins have direct cardioprotective effect independent of lipid lowering. So they have got a good protective. The heart is the main organ which is being affected by the lipids. So this is the effect of endothelium. Acetylcholine, decreases in the coronary vessel. So the acetylcholine is the neurotransmitter which is very important in the coronary vessel, which is very it produces EDRF. It has endothelial derived relaxing factor, and statin increases NO, nitrous oxide. So its dilative effect is being maintained. Endothelial dysfunction is reversed by statin. So endothelial function is being maintained. It is one of the statins are very important in a coronary vessel. So we can save our heart. So effect on plaque stabilization, inhibits the infiltration of the arterial wall, inhibits the secretion of macrophages. So here we have to note down that statins the metalloproteinase degrade matrix and weaken the fibrate cap of atherosclerosis plaque. So this is being preserved. Statins also appear to modulate the cellularity of the artery wall by inhibiting the proliferation of smooth muscle cells and enhancing apoptosis. So this it has been seen that these statins, they enhance the apoptosis. That means the cell death, and it maintains good health in the plaque. Where there is a plaque, it maintains it, and there is apoptosis. If the cell is there, the cell death under the regulatory method is being enhanced. So this is reducing proliferation of the smooth muscle cells and enhancing apoptosis, retards initial hyperplasia and restenosis. So it is not, plaque is being taken care of by these drugs. So effect on inflammation. C-reactive protein is the inflammatory for high-risk card patients. So it is a marker, and it also inhibits this C-reactive proteins. So effect on lipoprotein oxidation. Oxidation of a change in LDL occurs and important in the uptake of the lipoprotein cholesterol by macrophages. So cytotoxicity with the lesions. So statins inhibit the oxidative changes and thus subsequent issue. So this is very much important in this oxidative changes in LDL. So effect on the coagulation also is very good. Increased level of the fibrinogen may be involved in increased incidence of the card. Statins decrease platelet aggregation, so there is no chance of the clot formation. Also reduce the level of the fibrinogen. So this is protection for the heart. Now atorvastatin is the second drug. This newer and most popular statin is more potent, appears to have the highest LDL lowering efficacy at maximum daily dose. So we have 80 milligrams, so it protects and then it takes the care. At this dose, a greater reduction in TGs also is developed. So it reduces the TGs, is noted if the same was raised baseline. So the more the baseline, the more is the reduction. Atorvastatin has a much longer half-life. So its half-life is 18 to 24 hours, once a daily, and it has additional antioxidant property. So this is very important. Here you have to note down these things. And rosuvastatin is more stronger than atorvastatin. This is another newer commonly used and potent statin. It has 10 milligram of rosuvastatin is equal to 20 milligram of atorvastatin. So it is more potent with a plasma half-life 18 to 24 hours. So greater LDL reduction can be obtained to its longer persistence in the plasma. So it has a long half-life, so it reduces the LDL, and in patients with the raised TG levels, rosuvastatin raises HDL. So HDL also is being raised. So HDL is a good sign if it is raised by 15 to 20%, greater riser than the statins. Then potency of statins. Potency order for reduction in LDL is like rosuvastatin is more potent than atorvastatin. Atorvastatin is more potent than simvastatin, lovastatin, pravastatin, and fluvastatin. So rosuvastatin and atorvastatin are two drugs which are more potent. Potency order to reduction TG. So how TG level? Atorvastatin, pravastatin are there. Rosuvastatin is the third one. So TG potency reduction is like this. And potency order to increase the HDL is pravastatin and simvastatin. It should increase. So pravastatin, simvastatin are the drugs. So when there is a HDL you have to increase, the pravastatin, simvastatin is the drug of choice. And when there is a TG decrease, then it is the atorvastatin, pravastatin. Rosuvastatin is third one. But when it is a LDL, rosuvastatin is the first drug. So these are the potency order of these statins. Now HMG's reductase activity is maximum at midnight. Why we take at midnight? We take at night. So all statins are administered at bedtime. So this is called the chronopharmacology. So at the proper time we have to use it. And this is to obtain the maximum effectiveness. However, this is not necessary for atorvastatin and rosuvastatin, which have long plasma half-life. It does not matter. It is for those drugs which have got the shorter half-lives. So all statins except rosuvastatin are metabolized primarily by the CYP3A4. So rosuvastatin is not metabolized. So the drug interaction is not predominant in the rosuvastatin. So all statins we have to take care of because of CYP3A4. CYP3A4 is a very, cumbersome enzyme, this cytochrome 450. Now we have adverse effects, gastrointestinal complaints, we have headache, rashes, sleep disturbances, hepatotoxicity is there, rise in serum transmitters like alkaline phosphatase, and myopathy is there, risk in CPK levels. These are the, this is the muscle enzyme, peripheral neuropathy, cataract, lupus-like syndrome. So these are the adverse effects of these statins. Now, interactions. Interaction is very important. Enzyme inducers, we have phenytoin, rifampicin, that you have to remember forever, rhizophlavin and phenobarbital. And these, when we give these drugs with the, which are being metabolized by the CYP3A4 and lovastatin, simvastatin, atorvastatin, this reduces the concentration. So these are the inducers. Under this supervision, the drug level is decreases. Simultaneous consumption of the grape or its juice. You take the grape juice with the drug, so it increases the plasma level. That means it inhibits the drug. So the grape juice or any juice of grape type, it reduces the level. It reduces level means it increases the plasma concentration. It reduces the metabolism, and it increases the plasma level of statins. So the contraindication, we have liver disease and serum transminase, where there is a pregnant woman, lactating woman, trauma, major surgery we don't give. And therapeutic use, primary hyperlipidemias with raised LDL and total cholesterol levels, with or without raised TG levels. So we have to give in type 2A, 2B, and 5th, grade, which I have already mentioned. Secondary hypercholesterolemia, we have to give in the diabetes and nephrotic syndrome. These are the therapeutic uses where we have to give it. And now bile acid sequestrants. So this is the liver, HMG ceoredoxase, there is a bile acid, and then bile acid sequestrants plus bile acids. There is a complex formation and is excreted because the body uses cholesterol to make bile acids. So that's naturally, this reduces the amount of LDL. So amount of LDL is reduced, cholesterol circulating in the blood. So this is the main mechanism of action of the bile acids. So pharmacokinetics of these sequestrants. Bile acid sequestrants are largely polymeric structure, and they are not significantly absorbed from the gut in the blood system. So they are whatever lipids you take from diet and all that, it does not allow those to be absorbed in the from the intestine. So thus bile acid sequestrants along with any bile acid bound to the drug via the feces. So whatever the drug is you give, there is a drug-drug interaction, drug-food interaction we call that. So digoxin, if you give, digoxin level is not being attained in the systemic compartment because there is a sequestration. So therapeutic use, we give in the heterozygous familial hypercholesterolemia, type 3rd hyperproteinemia. So pruritus, digitalis toxicity, coronary artery disease. So if you have digitalis toxicity, you can give these sequestrants because they are not absorbing this drug digitalis in the systemic compartment in the blood. So we have gastrointestinal side effects: dyspepsia, bloating, constipation, gritty sensation, hypoprothrombinemia, reduced absorption of vitamin K. So this is also adverse effect, anticoagulant. Malabsorption of the folic acid, hypercholesteremia, acidosis, hypertriglyceridemia, dry flaking skin. So this is the side effects of these sequestrants. Now the interaction. Cholestyramine I have already told, and cholesterol are the drugs which are resin form. They bind and interfere with the absorption of many drugs. Like where thiazides, if you take the thiazide, these are being interacted by the sequestrants. And thiazides, furosemide, propranolol, levothyroxine, digoxin, warfarin, statins, pravastatin, fluvastatin. So these are being interacted, their level is being lowered, and the pharmacological action is not being ensured. So vitamin K, folic acid, ascorbic acid, contraindication. We have contraindication, we cannot give it in the severe hypertriglyceridemia or increased TG levels. So at TG level is the systemic component, so it is contraindicated. So these are the drugs which are being interacted by the cholestyramine and cholesterol. So these drugs you have not to give with these drugs. If the vitamin K also is very important, folic acid is very important, ascorbic acid is very important. So these drugs are being not given under when you have sequestrants. So lipoprotein lipase hybrids, we call it, halogenated hybrids, first generation club hybrid, second generation phenop hybrid, beza hybrid, and cyprop hybrid. These are called as a non-halogenated fibers. We have gemfibrozil, GMFIBROZIL, gemfibrozil. Now mechanism of action, hybrids reduce TG, activate nuclear receptor at PPR. It is the nuclear at the peripheral level, at the nuclear level, PPAR alpha. So we have it stimulates the beta oxidation of fatty acids. It increases the LPL synthesis. It reduces the production of the ApoC3, inhibits the lipolysis receptor mediated clearance. So VLDL clearance is enhanced. So clearance is enhanced. So this pharmacological, this fibrates mediated increased HDL. Or due to PPR stimulation. So HDL is very much increased. There's good, this cholesterol of ApoA and ApoA1 and ApoA second expression, which increase the HDL levels. So naturally, when we give these drugs PPR, this HDL level is increased. PPR may also mediate enhanced LDL receptor expression. So LDL expression is increased because at the nuclear side they act. In liver, seen particularly with the second generation fibrates like bezafibrate and fenofibrate. Fibrate is decreased hepatic TG synthesis. So TG synthesis being, decreased. This is another pathway. So pharmacokinetics, all of the fibrate drugs are absorbed rapidly and effectively, and 90% more. So their bioavailability is good when given with a meal, but less taken on the empty stomach. So empty stomach, they don't work. When you give a meal and so this is a drug which acts with the meal, which is acting more, that is bioavailability is increased, and less when we have an empty stomach. Naturally, we should take an empty stomach, like iron, like so many drugs, but here this is the opposite. The ester bond is hydrolyzed rapidly. Peak plasma concentration is obtained within 1 to 4 hours. The half-life ranges from 1.1 hour gemcitabine to 20 hours fenofibrate. They have got a large range of half-lives. The fibrate drugs are excreted predominantly by glucuronide conjugation. So it is the glucuronide which is being, then it has been transformed in the glucuronide. So it is 60 to 90% of all doses excreted. So the glucuronide is more water soluble and is being excreted from the, kidney. Now, adverse effects were gastrointestinal side effects, myopathy, rash, urticaria, hair loss, fatigue, headache, impotence, anemia, increase in serum transminase, and ALP. These, these enzymes are being increased by these drugs. So, therapeutic use of type 3rd hypercholesterolemia. So, you have to grade it. I already told you. Severe hypertriglyceridemia we give. Familial combined hyperlipidemia we give. Now, interactions, coagulants, they interact with coagulants, they interact with the gemcitabine plus servastatin, rhabdomyolysis. So, rhabdomyolysis is the, main, of the HMG-CO inhibitors. So, it precipitates. So, there is acute renal failure when we give these drugs. So, contraindication is pregnancy, renal dysfunction, and hepatic dysfunction. So these are the, contraindications. Now we have lipolysis and triglyceride synthesis inhibitors, niacin we call it. Niacin is pyridoxine 3-carboxylic acid, water-soluble vitamin B complex group. One of the oldest drugs is used in the treatment of the dyslipidemia. So as the niacin is an old drug, we have to take its advantage. It is an eldest drug. It is an oldest drug. Mechanism in adipose tissues it goes. Niacin inhibits the lipolysis. So inhibition of the lipolysis by the niacin is very much mechanism of action, and triglycerides by hormone-sensitive lipase reduces transport of the free fatty acids to the liver and decreases hepatic triglyceride synthesis. So hepatic triglyceride synthesis is being, decreased. Acting on GPR109A, niacin stimulates the GI adenyl cyclase. So adenyl cyclase is guanosine protein. It is being inhibited pathway in adipocytes, inhibiting cyclic AMP production and decreases the hormone-sensitive lipase activity, triglycerides, lipolysis, and release of free fatty acids. So, in the nutshell, niacin also may inhibit the rate-limiting enzyme of the triglyceride synthesis, diacylglycerol, that is the calcium sequestrant, and acetyltransferase 2. These are being enzymes which are being inhibited by the niacin. And then in the liver, niacin reduces the triglyceride synthesis by inhibiting both the synthesis and the esterification of fatty acids. That increases the ApoB degradation. So reduction of the triglyceride synthesis reduces hepatic VLDL production, reduces LDL levels. So niacin also enhances LPL. With the result, what happens? LPL activity promotes the clearance of the chylomicrons and the VLDL triglycerides. So they are being enhanced. They enhance the clearance. So with the result, niacin raises HDL-C. So HDL is being increased by decreasing the fractional clearance of ApoA and HDL rather than by enhancing HDL synthesis. So HDL is raised. This effect is due to the reduction of the hepatic clearance of the HDL ApoA1 but not of cholesterol esters, thereby increasing the ApoA content of the plasma and augmenting reverse cholesterol transport. So this, in the nutshell, the niacin, this reduces the HDL levels. So the adverse effects is the flushing, gastrointestinal dyspepsia, vomiting, diarrhea, hepatotoxicity, elevated transminases, and you will see this transminase elevation and hepatotoxicity is more common in these drugs, whatever anti-lipids. And hyperglycemia is there, ocular toxic, amblyopia and maculopathy. So ocular, ophthalmologic side effects, cardiovascular atrial tachyarrhythmia and atrial fibrillation. So we have to discard these in cardiac diseases. So interaction postural hypotension may occur in patients with antihypertensives. So we have to see those patients which are hypertensive patients, and they are taking antihypertensives. They are prone to have this postural hypotension. When they take nicotinic acid, risk of myopathy due to the statins is increased. So statins and nicotinic acid is not the good combination. Diabetes mellitus cannot give peptic ulcer, pregnancy and gout, because these are the precipitants of these things. Now we have the ezetimibe. This is the cholesterol absorption inhibitor. It also acts as in the intestine. It's a novel drug that acts by inhibiting the intestinal absorption of the cholesterol and phytosterols. So cholesterol and phytosterols at the intestine is being inhibited by this ezetimibe. Lowers plasma cholesterol level by inhibiting the absorption from intestine naturally. This